Research in geriatric pharmacology consistently suggests that up to 1 in 4 seniors taking both a pain reliever and a water pill may be quietly harming their kidneys.
And most of them have no idea, not because they did something wrong, but because no one, not their doctor, not the label light, ever told them these two don't mix.
2 medications, both prescribed, both considered safe. But when they meet inside an aging kidney, the result is something most people would never expect. Before I explain exactly what that is, I need you to understand one thing about your kidneys after 60. Without that context, the rest of this won't fully land. Your kidneys are not just filtering organs. They are pressure managers, blood flow managers. And after 60, Dorothy is 74, retired librarian, arthritis in both knees that makes walking painful. She also has mild heart failure. Stay with me, Hal, because this combination is not rare. It may already be in your medicine cabinet, and the damage it causes is slow.
Her cardiologist prescribed furosemide, or a water pill pied, to help release that fluid. Her internist said it was fine to take Advil for her knees as needed.
Let me walk you through what actually happens. And to make this real, I want to tell you about someone I'll call Dorothy. And here's where the problem begins. What Dorothy's 2 doctors never discussed with each other, or with her, is what happens next. What happens when a non-steroidal anti-inflammatory drug and a loop diuretic meet inside an aging kidney at the same time?
To understand that, I need to explain something called prostaglandins. Bear with me for 30 seconds, Pawn, because once you understand this, everything else will click.
Prostaglandins are molecules your body makes naturally. Among many jobs, they have one specific function inside your kidneys.
They help dilate the small arteries that supply blood to the kidney tissue. Think of those arteries as the irrigation lines of a garden.
NSAIDs, medications like ibuprofen, naproxen, Advil, work by blocking the production of prostaglandins. That's how they reduce pain. It works.
But inside a kidney already under pressure from a diuretic, blocking those prostaglandins is like closing the irrigation lines while the garden is in a drought.
This is called NSAID-induced renal impairment, a recognized pharmacological interaction. And in my experience, it almost never gets blood flow to the kidney drops. The tissue receives less oxygen, less pressure, less supply. And it compensates Paul until it can't. Why? Because appointments are short. Both drugs were prescribed for legitimate reasons. The harm doesn't show up on day 1. It builds.
Her nephrologist thought it was simply aging. Her cardiologist adjusted her diuretic dose. Neither looked at the Advil.
Dorothy's creatinine, that a marker of kidney function, had been climbing for 6 months before anyone connected it to her medications. It wasn't until she mentioned, almost offhand, that she'd been taking just a couple of Advils every day for her knees pass that I put the 2 pieces together. Pressure point 1. Reduced renal blood flow. NSAIDs block prostaglandins. Prostaglandins keep the afferent arteriole open, and we were able to stop the damage before it became permanent. That's the story I want you to understand today. Not to alarm you, Paon, but to prepare you.
Let me show you the 4 ways this interaction puts pressure on your kidneys. I call these the 4 pressure points. In a young kidney, this is usually tolerable, but after 60 Po, where reserve is already reduced Po, even a modest drop in blood flow is meaningful.
Research consistently suggests NSAID use, even short-term now, can reduce kidney blood flow by 15 to 20% in seniors over 65.
Most people would describe that as just taking something for the pain. They have no idea their kidneys are receiving 15% less supply while they do it.
Pressure point 2, blunting of diuretic effectiveness. NSAIDs don't just affect the kidneys directly, they reduce the effectiveness of your diuretic, the medication your heart depends on.
Diuretics like furosemide work partly through prostaglandin pathways in the kidney. NSAIDs interfere with those same pathways.
The result, your water pill doesn't pull as much fluid as it should. Your body retains sodium. Your blood pressure edges up. Your heart works harder.
This means Dorothy's Advil wasn't just potentially harming her kidneys. It was quietly making her heart failure harder to manage at the same time.
Pressure point 3, sodium and potassium imbalance. NSAIDs cause sodium retention. Diuretics try to expel excess fluid. The result is internal tension. Elevated sodium, fluctuating potassium, a kidney receiving conflicting signals and trying to satisfy both.
Over time, this metabolic friction accumulates in ways that show up on blood tests long after the damage is already underway.
Pressure point 4, cumulative vulnerability. Every kidney loses filtering capacity with age, roughly 1% of GFR. But a kidney already compensating for lower baseline function, now receiving less blood flows, managing when the lines are open town, when prostaglandins are doing their job, the kidney gets the blood flow it needs to filter properly. The garden stays alive. An infection, dehydration on a hot day, a contrast dye for an imaging test. Any of these can push a struggling kidney into acute injury.
That's the moment things go from, my creatinine is a little elevated, to, you need to be admitted.
And the admission note often doesn't mention the Advil. Because the patient didn't think to mention it. Because it's just Advil. Now, Krang, I am not telling you this to make you afraid of your medications. Both NSAIDs and diuretics are valuable drugs. People need them. They have real clinical roles. What I am telling you is that the combination, in a body over 60, deserves more attention than it typically receives. And there are Let me walk you through what I tell patients in Dorothy's situation. Not stop taking your medication. That's not safe advice without knowing your full picture.
First, make your pharmacist your medication coordinator. Most seniors have one doctor for the heart, one for joints, one for primary care. Your pharmacist sees the whole list.
We're trained to catch exactly this kind of interaction, but only if we know what you're taking path, including everything over the counter. Bring every bottle to your next pharmacy visit and ask for a medication interaction review. It takes about 15 minutes. It can be genuinely life-changing. Second, ask about alternatives to oral NSAIDs. If you have joint pain and also take a diuretic for your heart, this means less of the drug reaches your kidneys and bloodstream. Topical diclofenac provides meaningful relief for knee pain with substantially reduced kidney risk. Acetaminophen at appropriate doses is also a reasonable option for mild to moderate joint pain. It doesn't carry the same kidney and diuretic interaction risk.
Third, know the warning signs of early renal strain. Your kidneys will usually give you signals before they give out. The problem is those signals are easy to dismiss as getting older.
Swelling in the ankles or legs getting worse, even though you're taking your water pill pie, may mean the diuretic isn't working as it should. Report it. Urine that looks darker than usual, or significantly less of it pain, your body telling you kidney filtration has slowed. Always worth a call. Fatigue or brain fog increasing gradually over weeks pound. Sometimes the only symptom of waste products the kidneys aren't clearing efficiently.
Any new swelling in the face or hands combined with a headache can indicate blood pressure elevation from this interaction. Prompt attention, not let me wait and see.
Fourth, and this one matters most, ask for a baseline creatinine check. If you're taking both an NSAID.
These are simple blood tests that show how well your kidneys are filtering. If function is normal, you have a baseline. If it's elevated pay, that changes every decision going forward.
You cannot make informed decisions about your medications without knowing where your kidneys stand right now. I want to spend a moment on who is most vulnerable to CANs, because the risk is not evenly distributed. The highest risk profile, over 70, taking a loop diuretic for heart failure or high blood pressure, and taking any NSAID more than twice a week.
The risk increases further with any history of elevated creatinine Q, even borderline. That means less reserve to absorb the additional pressure of this interaction.
Dehydration amplifies the risk significantly. Summer months, dry climates, illness with vomiting. Diabetes is also a significant multiplier. Diabetic kidneys have structural changes that make them more sensitive to blood flow disruptions. And here's something that surprises most people. This risk applies to over-the-counter NSAIDs taken at the recommended dose. This is not a "you're taking too much" problem. The mechanism operates at normal doses in a vulnerable kidney. Dorothy was not taking more than the label said. She was taking it for genuine pain, believing it was safe. No one had ever flagged the combination with her diuretic.
That's not negligence. It's a system not designed to catch this kind of slow, multi-drug interaction in an aging body, which is why conversations like this one matter.
Let me bring this together. 2 medications now, one for pain, one for fluid. When they meet inside an aging kidney, they create 4 points of pressure: reduced blood flow, blunted diuretic function, sodium and potassium imbalance, and cumulative vulnerability that leaves your kidney with very little reserve. The damage is quiet, rarely causes obvious symptoms until it's advanced, and almost always preventable. Dorothy's story did not end in dialysis. It ended with topical diclofenac gel for her knees, a creatinine check 6 weeks later showing her levels had stabilized.
And a patient who now brings every bottle and every single one towel to my counter when she picks up her prescriptions.
You now know something most people your age don't. You understand the mechanism behind one of the most quietly damaging drug interactions in senior medicine. And that knowledge gives you the power to ask better questions. Not to second-guess your physicians. Well, to collaborate with them.
To walk into your next appointment and say, I've been reading about NSAIDs and diuretics in seniors. Can we review my list together?
That sentence alone could protect your kidneys. If this conversation gave you something worth knowing, share it with someone who needs it.